Welcome to this NCLEX-ReviewPro explainer. Okay, let's jump right into mastering infection prevention and control, or what we call IPAC. Listen, if you're a nursing student gearing up for the NCLEX, you already know that infection control isn't just some boring chapter in a textbook, right? It's literally the absolute foundation of safe nursing practice. So today, we're going to build your ultimate IPAC blueprint. We'll be focusing heavily on standard and transmission-based precautions, making sure you can confidently spot them and apply them the second they pop up on exam day.
Now, you might be wondering, why does the exam hammer the specific topics so hard? Well, here's the secret. Isolation questions are, at their core, strict safety questions. The NCLEX is trying to figure out one thing. Are you safe to practice as a brand new nurse? If you choose an intervention that compromises safety, like, say, picking alcohol sanitizer for a spore-forming bacteria, you fail that question. It's really that simple. Protecting yourself, protecting your patient, and protecting everybody else on the unit from the spread of infectious disease is always your #1 priority. So here's our roadmap for today. We'll start with the infection safety framework, then hit standard, contact, droplet, and airborne precautions, and we'll wrap up the whole shebang with high-yield NCLEX priorities. Let's get into it.
Section 1, the Infection Safety Framework.
Okay, breaking the chain of infection basically means you have to methodically follow 3 exact steps. Step 1, identify the organism. What exactly is the infectious agent we're dealing with? Step 2, determine its mode of transmission. Does it spread through direct touch? Is it riding on large respiratory droplets? Or is it floating around as tiny aerosolized particles? And finally, step 3, select the correct protection. Because look, if you know exactly how the pathogen travels from point A to point B, you know exactly which barriers you need to throw up to stop it dead in its tracks. Moving right along to Section 2, Standard Precautions and Universal Care. Standard precautions are our baseline. These are routine practices that we use universally on absolutely everybody. The core assumption you need to make here is that all blood, all body fluids, mucous membranes, and non-intact skin are potentially infectious. You don't sit around waiting for a lab result to confirm it. You just assume the risk is always there, every single time. And that means performing hand hygiene before and after patient contact, and wearing clean gloves when touching anything that might be contaminated. These are the 2 absolute, non-negotiable rules of standard precautions. Whether you're emptying a urinary catheter bag or you're just taking off a pair of gloves, you've got to clean those hands. It's hands down the single most effective way to prevent germs from spreading like wildfire.
All right, Section 3, contact precautions for direct touch.
So if a pathogen can be picked up just by touching the patient or their environment, like bumping into their bed rails or grabbing something off a bedside table, you absolutely need contact precautions. The high-yield diseases they love to test include MRSA, VRE, C. difficile, scabies, and RSV in infants. For all of these, your required PPE is a gown and gloves the second you enter the room. You're literally putting a physical barrier over your scrubs and skin so you don't accidentally carry these bugs down the hall to your next patient.
Now listen closely, because this is a massive, unmissable NCLEX trap. Clostridium difficile, or C. diff. Because C. diff spreads through super tough endospores, your standard alcohol-based hand sanitizers are entirely useless. They literally do not get rid of the spores. You have got to wash your hands with soap and water. If you see a test question asking what to do after leaving a C. diff room, immediately look for the soap and water option. Do not fall for the sanitizer trick.
Phrase is way more straightforward. Don medical gloves and gown with every contact precaution session. It literally tells you the exact protective gear to wear right there in the sentence, while holding the keys to the pathogens you're going to encounter.
You definitely know the drill here. Anytime you're dealing with diarrhea, like C. diff, medication-resistant bugs like MRSA or VRE, or a wound with excessive drainage, you fall right into this category. The rule is incredibly simple. You must immediately glove and gown up. And remember, things like skin infections or RSV spread like wildfire through direct contact or just contaminated environments. So those physical barriers, completely non-negotiable.
Section 4, Droplet Precautions and the 3 feet rule. Okay, the magic number you need to lock into your brain for droplets is 3 feet. That's roughly how far these heavy droplets travel in the air before they just fall to the floor. The heavy hitters you'll see here are influenza, bacterial meningitis, pertussis, which is whooping cough, and mumps. If you're going to be within 3 feet of a patient with one of these, you have to wear a standard surgical mask. It's a really simple intervention, but it completely blocks those heavy, germ-filled droplets from making it into your nose or mouth.
Brace yourselves, because we have another wild mnemonic here to remember droplet-based pathogens.
Whose adjustable drop mask stops scary pneumatic fluid parasites plaguing distinguished German men my epic mumps Rhonda? Yeah, it is quite the mouthful, but it packs in a massive amount of clinical data. Let's break it all down.
Okay, let's run through this clinical checklist. Drop and mask are your anchors, reminding you this is Droplet Precautions and your primary defense is a standard surgical mask. The rest maps out the major threats. Whose is whooping cough, adjustable is adenovirus, then we have strep, scarlet fever, pneumonia, the flu, all the way down to mumps and rhinovirus. The big takeaway here? For larger particles like the flu or whooping cough, an N95 is overkill. A regular surgical mask, along with your standard hand hygiene, is exactly what you need to stop transmission in its tracks.
Section 5, Airborne Precautions and Aerosolized Particles. For airborne, I want you to think of it like spraying air freshener in a room. The infectious particles are so incredibly tiny that they basically defeat gravity. They stay suspended and just ride along on air currents for long periods. Because these pathogens hang out in the air just waiting to be inhaled, these patients require strict environmental controls. The classic NCLEX airborne infections you need to know are tuberculosis, measles, and varicella, which is chickenpox. These patients absolutely must be put in a private, negative pressure room. The door stays closed, and the room actively sucks air out through a special filter, making sure no infectious particles drift out into the hospital hallway.
And take a look at the contrast between these masks, because the NCLEX loves to test this exact distinction. An N95 respirator is what you, the nurse, wear to go into an airborne room to protect yourself from inhaling those tiny suspended particles. But a standard surgical mask? That's used for droplet precautions, and its main job is actually to protect everyone else from what the wearer is exhaling out.
Right, speaking of traps, here is another huge one to watch out for: isolation combinations. Varicella or chickenpox is the perfect example. The respiratory particles of varicella require airborne precautions and a negative pressure room. But the patient also has highly contagious oozing skin lesions which demand contact precautions. So for varicella, you actually need an N95 respirator plus a gown and gloves. And just as a quick side note, disseminated shingles requires this exact same airborne and contact combination.
Okay, to lock this into your memory for the NCLEX, or honestly just your next shift, we're going to use a completely wild but brilliant mnemonic. Read this aloud with me. Airborne chicken number 95 dissected her tubby mealworm. I know, no way you're forgetting that, right? It's bizarre, but it is the ultimate key to instantly recalling airborne pathogens.
So let's actually decode that. Airborne obviously tells you the precaution type. Chicken is for chickenpox. Number 95, and this is absolutely crucial, is your reminder that you must wear an N95 mask at all times. Dissected her stands for disseminated herpes zoster, or shingles. Tubby is tuberculosis, and mealworm is measles. Actually, quick side note here, chickenpox and disseminated herpes zoster also require contact precautions, so you'll be throwing on a gown and gloves with that N95.
Finally, Section 6, High-Yield NCLEX Priorities.
Okay, you will absolutely see questions on the exact sequential order for putting on or donning your PPE. After you do your hand hygiene, you want to think from the bottom up and inside out. A fantastic memory hint from the source material is GMEG: gown, mask, eyewear, gloves. You put the gown on first to cover your torso, then your mask or respirator, then your goggles, and finally your gloves go on last so you can pull them securely over the cuffs of the gown. Now contrast that directly with doffing, which is taking off your PPE. The logic here is beautifully simple. You have to remove the dirtiest, most contaminated items first so you don't contaminate yourself. Your gloves touch the patient, meaning they are the dirtiest, so off they go first. Then your eyewear, then your gown. Your mask comes off last, usually right at the door or right after you exit an airborne room. And the final, absolutely most important step, always end with hand hygiene.
We've all seen people do this wrong, right? So when executing mask protocols, notice the non-negotiable progression. First, proper hand hygiene. Second, handle the mask only by the ear loops or ties. And finally, secure it completely over your nose and mouth. You should never, ever touch the front of the mask while you're wearing it, and absolutely do not let it dangle around your neck. That literally just cross-contaminates your entire uniform.
Now for those airborne threats we talked about earlier, your N95 is your best friend. Following this precise sequence for putting it on and carefully removing it is absolutely critical. Notice the emphasis on placing the top strap high on the back of the head, molding the nose piece, and doing a proper seal check. And when you take it off, you only handle the straps from behind. Never touch the contaminated front surface of that respirator.
To sum up the absolute golden rules across all of these precautions, just follow these 4 steps. Practice hand hygiene first and last. Put the gear on right before the task. Take it off immediately when you're done. And maybe most importantly, do not wear PPE when it's not needed. Wearing a gown or gloves down the hallway when you shouldn't be is a prime way to accidentally contaminate your broader clinical environment.
So, what happens when these isolated patients need to go get an X-ray or head to surgery? Well, the golden rule is to limit transport as much as humanly possible. But if an infectious patient absolutely must leave their room, you need to establish source control. If they are on airborne or droplet precautions, they are the ones who must wear a standard surgical mask during transport. Remember our mask rule from earlier? The surgical mask on the patient protects the rest of the hospital from their exhaled pathogens. To bring this all together into one clear picture, let's just review these precautions at a single glance. Contact means gowns and gloves for bugs like MRSA and C. diff. Droplet means a surgical mask within 3 feet for things like the flu and meningitis. And airborne requires an N95 and a negative pressure room for TB, measles, and varicella. Seriously, lock this table into your memory. We're going to end on this thought. If you choose the wrong isolation precaution on the NCLEX, whose safety are you ultimately compromising? Well, the answer is everyone's. Yours, the patient's, and the whole community's. These aren't just tricky test questions to trip you up. They are essential safety lifelines. Master this blueprint, protect your patients, and you are going to be more than ready to completely crush the NCLEX.
Brings us to the Point of Care Risk Assessment, or PCRA. This is your absolute first, non-negotiable step. Literally before every single interaction, you have to evaluate the task you're about to perform, the environment you're walking into, and the resident's current condition. Basically, your PCRA dictates exactly what PPE you need to wear before you even cross the threshold to provide care.
Okay, let's put this into practice. Imagine you're out on the floor, doing your point-of-care risk assessment outside a room. The resident suddenly develops a brand new cough, a runny nose, and intense sneezing. You don't have a diagnosis yet. This sudden respiratory scenario hits. What is your exact protocol before you even step forward to provide direct care? If your clinical instincts kicked in, you know this requires going all in. The only correct protocol here is to perform hand hygiene and immediately don a gown, a medical mask, eye protection, and gloves. Since the symptoms are undiagnosed, you are using your additional precautions to fully protect yourself from unknown droplets and contact transmission until you actually have a confirmed diagnosis. Understanding organisms and memorizing mnemonics is fantastic, but translating all of that into physical action is what actually saves lives. So, I'll leave you with this final thought. On your very next shift, will you have the discipline to pause, perform your risk assessment, and put on the exact right armor before you cross that threshold? Keep this knowledge sharp and stay safe out there.
Hey everyone, let's jump right into this explainer. Going through these foundational clinical guidelines, I actually realized I had this massive misconception about hospital safety. I mean, we so often think of safety as just, memorizing those colorful posters on a break room wall, but it's not. It's actually a highly structured operational sequence. Think about this for a second. If a piece of life-sustaining equipment suddenly starts sparking in a patient's room, who do you call first? I bet instinctively your gut says call maintenance or engineering, right? Get rid of the hazard. But in real life, and definitely on clinical exams, the absolute top priority is always, and I mean always, protecting the patient with a backup plan first. You secure the patient, then you remove the hazard, and only after all that do you escalate and report the issue. It's totally backward from what most of us might guess. So, here is our roadmap for today. First, we'll cover navigating environmental hazards. Second, priorities in bedside procedures. And third, responding to medical errors. All right, let's start broad with Section 1, environmental hazards and how we navigate room threats. Now, when dealing with a fire, safety isn't just a suggestion. It's a strict, unyielding sequence. We call it RACE. First, you rescue or remove the patient. Then, activate the alarm. Next, contain the smoke by closing the doors. And finally, extinguish or evacuate. You absolutely cannot swap these steps around without putting lives in serious danger. It's a literal lifeline. And hey, if you actually make it to that final step and need to use an extinguisher, well, there's a specific physical sequence for that too. Pass. Pull the pin, Aim at the base of the fire, squeeze the handle, and sweep side to side. It ensures maximum effectiveness when literally every single second counts. So the huge takeaway here is that sequence is everything. And that means dodging some really common traps. A major one? Trying to play hero and put out a fire before sounding the alarm. Do not do it. The patient and the alarm always come first. Also, we really have to watch out for oxygen. Now, oxygen itself doesn't burn, but man, does it accelerate combustion. Just one spark near an oxygen setup can turn a minor issue into a total disaster in the blink of an eye. Moving right along to Section 2, bedside procedures and our immediate priorities. Okay, by quickly mapping out these bedside red flags, we can see exactly what our immediate priority actions have to be when managing tubes, drains, and eliminations. Take nasogastric or NG tubes, for example. The major complication there is misplacing it into the lungs, so your immediate priority is strict X-ray confirmation. For Foley catheters, the main goal is preventing infections, specifically CAUTI, which stands for catheter-associated urinary tract infections, meaning the priority is to get that thing out of there as soon as medically possible. And for continuous bladder irrigation, or CBI, the big risk is a clot obstruction. So what's your immediate action? Check the system for kinks and meticulously track that flow. Now here is a really surprising fact straight from the guidelines. When it comes to blind feeding tubes, pushing air in and listening with a stethoscope, which is known as air bolus auscultation, is totally unreliable. No joke, it's just not safe. Initial X-ray confirmation is absolutely required. If a new tube hasn't been verified by an X-ray, you simply do not start feedings, period. When we're checking an ostomy, color is going to be your absolute best indicator of tissue health. An expected healthy stoma is red or pink and moist. Kind of like a healthy gum line, you know? But if you see a dusky, pale, gray, or black stoma, wow, that is a medical emergency. That color change basically screams compromised blood flow or necrosis, and it requires urgent surgical evaluation. It's super easy to overreact to a tiny bit of bleeding during routine cleaning, but whatever you do, do not underreact to these severe color changes. Now, looking at continuous bladder irrigation, there are a few very specific, highly testable traps you need to avoid. Remember, you're popping fluid into the bladder to clear out clots, usually after urologic surgery. The trick here is that you have to calculate the true urine by subtracting the instilled irrigant from the total drainage. If you forget to subtract, your output numbers are going to be completely, totally wrong. And on top of that, you can't just ignore severe suprapubic pain. If the inflow is greater than the outflow and your patient is in agony, you have to assume it's a dangerous obstruction until proven otherwise. When it comes to enteral feeding, gravity is absolutely your best friend. Always keep the head of the bed elevated about 30 to 45 degrees to prevent aspiration. Oh, and please didn't make a medication smoothie. You should never mix multiple crushed medications directly into the feeding formula. They have to be administered separately using water flushes in between, just to keep the tube clear and make sure the meds actually work the way they're supposed to. All right, bringing it home with Section 3, responding to errors and dealing with the aftermath. When things inevitably go wrong, the chronological sequence we follow is strictly defined. Notice exactly what happens first here. Assess the patient. Then, stop the ongoing harm. After the patient is fully stabilized, you notify the provider, and then you document the clinical facts. Literally only at the very end of this entire process do you even think about filling out an incident report. You've got to assess and rescue the patient way before you ever touch a variance form. I honestly found it fascinating how much this whole process has evolved. Instead of the old-school default of concealment, modern safety systems use frameworks like the AHRQ's Candor model. This model really pushes for early, honest, and empathetic communication with patients and their families after unexpected harm. It prioritizes transparency when the facts are actually known, way over dodging the issue or burying your head in the sand. And you know, this kind of transparency feeds right into what's called a just culture. It's a systems learning model that actively separates a simple human error from truly reckless behavior. When a near miss happens, the focus is placed heavily on fixing the system that allowed it to happen in the first place, rather than just reflexively punishing a single nurse or doctor. The whole idea is to fix those weak links before actual irreversible harm happens to a patient. So when you're documentating these safety events in the health record, your language matters immensely. You've got to stick to objective patient facts and interventions. Think, patient found on floor, awake, blood pressure 146/82. You should absolutely never use the patient's chart to assign blame, offer opinions, or speculate. Never write something like, incident report done because of bad staffing. The medical chart is strictly for clinical facts, not for airing out grievances or referencing risk management paperwork. If there's one thing you take away from this entire explainer, it should be this. Hospital safety isn't just about memorizing a bunch of random, disconnected rules. It is a relentless, chronological focus on rescuing the patient first. Whether you're dealing with a fire, a malfunctioning IV pump, or a medication error, safety is a sequence. The immediate well-being of the patient always, without fail, takes absolute precedence over paperwork, systems, and property. So I'll leave you with this thought to chew on. Safety protocols really only work if they become pure muscle memory. If a piece of equipment sparked in your room right at this very second, are you mentally prepared to execute that sequence of safety? What hazard might you be completely overlooking right now just because you haven't put it into a sequence? Stay observant out there, and I will catch you in the next explainer.